I've been involved in many conferences around the world, and I just feel compelled to mention to you the World Research Foundation, the talent, the work. Pulling this thing together is unique, is magnificent. I'm just honored to be here, and I think we all owe a debt of gratitude to Steve and Laverne. Thank you very much. Next thing, we're going to cover a lot of ground this morning with hyperbaric oxygen. And I don't want to give you a talk, I want to talk with you. I want you to interrupt me at any time. We'll go through some most complex slides that I will attempt to simplify for you and attempt to get the basic message across. So please, let's make this terribly informal, and don't hesitate to interrupt me or say, I don't understand that slide, what are you trying to tell us? Now, how many of you have ever seen a hyperbaric chamber? That's remarkable. If I had addressed an audience of pure MDs this size, 2 or 3 hands would have been startling. This is probably the best kept secret since the atom bomb in the Second World War. Oxygen is undoubtedly the most indiscriminately used drug in the world. It's the only reason we're on this planet. You can do without water for a while, and Jesus fasted for a number of days, but without oxygen for 5 minutes, you're in trouble. When it was discovered in the First World War in 1919 that this was helpful in an oxygen tent, the medical profession reacted violently and said, you're going to poison and kill the soldiers. Then again, at the beginning of the Second World War, when they found intravenous fluids could be used, the same reaction came forth. You're going to drown, you're going to kill these people. We are accused of various things with hyperbaric oxygen, but let me tell you what it is. It's simply the use of oxygen at greater than atmospheric pressures. It's just that simple. Basically, all diseases and illness occur in the tissues, that is, out yonder, with the exception of a catastrophe in a blood vessel. Now, out yonder in the tissues, whether it be the brain with a stroke, the foot with gangrene, the bone with an infection, the muscle with gas gangrene, there's one common denominator to all illnesses, and that is hypoxia, or a low oxygen content in the tissues. Nature has put us together such that we do not heal unless the oxygen content is appropriate or correct. All hyperbaric oxygen does is to increase the oxygen gradient in the tissue. Nature does the rest. There is no magic to anything I'm going to tell you this morning. So we want to talk about tissue healing and regeneration prompted by hyperbaric oxygen. Let me say that this modality may make the difference between life and death, coma, non-coma, paralysis and non-paralysis, and yet is taught only in a few medical schools. I'll just skirt some rapid examples so we can get into the meat of the talk. Life and death is air embolization. This is the most severe type of decompression illness, but it also occurs with open heart surgery, with kidney dialysis. It can even occur after simple venipuncture. Air gets into the system, it goes to the brain and causes an air stroke. The most tragic situation is the young sports diver who can come up inappropriately from as little as 6 feet. They come up, they have headache, nausea, vomiting, and equal pupils. There's no question as to the diagnosis. You have about 30 to 40 minutes usually to get these people to a recompression or hyperbaric oxygen chamber. If they are taken to the chamber, they have a 95% chance of total recovery. If not, they will either be dead or permanently maimed. Another life and death situation in which there is no other type of treatment is carbon monoxide intoxication. This is the most common poisoning in the world and accounts for about 25,000 deaths a year. Carbon monoxide poisons the brain, it poisons the heart. Hyperbaric oxygen completely dissociates the molecule that it forms and furnishes oxygen to all the tissues. The results are rather remarkable, and there have been lawsuits up to $4 million for failure to use this, yet it has not become generally acceptable in the United States. Paralysis and non-paralysis are spinal cord hit of decompression illness, stroke, Guillain-Barré syndrome, and coma, non-coma are closed head injury, and the vegetative state that we talk about as the morning goes on. Again, no magic to oxygen as a gas. It adheres to all the gas laws. The one that we refer to most frequently is Henry's law. And if you remember your high school physics, all this says is if you put a gas under more pressure at constant temperature, more of it will be dissolved in any liquid. Now, to the patient, what this means is the higher the pressure, the more oxygen dissolved in all body fluids. That's cerebral spinal fluid, blood, plasma, bone, and urine. So here we have a way of increasing the oxygen gradient or the oxygen content in the tissues. Boyle's law says that as, for instance, a diver comes up, the gas expands, and this is where a lot of the decompression illnesses occur, even in the best of hands. Now, oxygen under pressure is given as a dose. And let me assure you, this is in no way related to the little green masks or the catheters they put up patients' nose. That is referred to as isobaric oxygen, or just oxygen in the little green tank, the little green mask. That is the most indiscriminately used product in the world. All high-rises have them, all ambulances. Many people have them in their home, and irrespective of what happens, the patient gets oxygen. It's supposed to be the universal panacea. Probably 95% of those patients do not need oxygen. Under those circumstances, it's used indiscriminately. When we hyperbarists use oxygen, we use it in a dose. We use it for certain reasons, such as animal experimentation data, clinical data, and a reasonable expectation of its use, and we keep it in a very safe dose. But like any good drug, digitalis, aspirin, in excess, it can be a poison. The dose has been very well worked out, and we go in the range of 1.5 to 3 ATA, which the atmosphere is absolute, and that's equivalent to 2280 millimeters of mercury, or basically 66 feet below sea level. Hyperbaric oxygen in neurologic conditions is similar to insulin in the diabetics. That is, the dose is different for each patient, and the length of treatment is different for each patient. So we have a dose-specific drug here with hyperbaric oxygen. This is a complex slide. This and the next, there are only two figures I want you to look at. See, this 2,000. Is there a focus on this, Steve? This part seems to be out of focus. I don't see one on the remote. You want me to move? You can't see it? All right. All right. This is 2,000. What this is this is the blood level of oxygen in a patient receiving 3 atmospheres of 100% oxygen. Now, at sea level, the blood level would be about 90, but here we have a level of 2,000. Now, just remember that figure. That's in the artery. Now, same time, minute or two later, in the vein, we have a level of 385. And since we know that the circulation is a closed system, this brings up a pretty good question. Where did it go? Well, it went to the tissue spaces where it belongs. Went to the mitochondria. It went to the vital and living parts of the body. So here we have a way of unequivocally delivering excess oxygen to the tissues. But, of course, life is never that simple. Will this focus better, please? There we go. There are certain factors that must be considered, such as what's the condition of the lung? Does the patient have emphysema? Is the patient in pulmonary edema? What's going on there? At the interface, that is, can the inhaled, inspired oxygen get into the blood? And then the conducting fluid. How is the blood? Is it too thick? Is it too thin? Is there any blood? Then the pump mechanism and the condition of the arteries to deliver it. And then finally, the longest mile is the diffusion interface between the capillaries and the recipient tissues. So although theoretically we can deliver this, just that final mile is what really counts. Now, please interrupt me if there are any questions so far. That what we've talked about basically is the carriage or the delivery of oxygen and the dose. Again, the dose is the depth of pressure and the length of time. Any questions? I can't see a thing with the light if you just...
How effective is that?
Excuse me. If there are any questions, please come to the microphone so everyone can hear.
How effective is this for somebody that's dying of emphysema?
It's virtually not used in the United States. It is, however, standard treatment in Italy, has been for about 25 years, and the results with chronic obstructive pulmonary disease, which is what emphysema is, are really remarkable. I would refer you to Dr. Raffaele Pallotta in Napoli. He's been doing it for 25 years, and the results are really outstanding. We'll get into the various clinical conditions in a little bit now. Are there any further questions? Let's talk about the types of chambers then. This is a big boiler-like chamber. This is called a multi-place chamber. And what that means is you can treat more than one person at once. It means you need a fairly good-sized room. You need to adhere to all the OSHA requirements because this will go to depths of 165 feet, which is 6 ATA. And it takes an engineer to run it on the outside, and on the inside you can even have surgery performed. So this is an expensive operation, but if necessary you can operate in a chamber like this, and you can treat up to 10 or 20 patients at a time. Such as there was a ship off the coast of Miami about 2 weeks ago where they had about 10 cases of carbon monoxide poisoning. The unfortunate thing is there was a chamber. They took all the cases to the chamber. The chamber was closed. And 2 of the patients died while they were looking for other chambers. So this is the multi-station chamber, more than one. The delivery of oxygen here is by mask. This chamber is compressed with air. This is a monoplace chamber. Now, the cost of the multi-place chamber is in the range of $1 million installed. Now, this is an acrylic glass tube. It'll do the same thing. The only thing is you can't operate in here, which is really not done anyhow. But this can be wheeled up to the emergency room. It can be wheeled to a patient's room. The cost here is about $70,000. This can be run by an intensive care nurse or a respiratory technician. And here is another type. This is a cantilever type. Here the oxygen compression is the way the chamber is given depth. So the compression takes place only with oxygen, not with air. In the multi-station chamber, the mask that fits me may not fit you, so there is some question as to accurate delivery from patient to patient. This becomes important when you're dealing with dose-sensitive conditions. But in the little monoplace fellow, you compress with oxygen so there's no error in the dosage. I had a patient with multiple sclerosis that we treated about 6 years ago, and he had it in the brainstem. I'll show you some of his slides as the morning goes on. He took about 30 treatments and really did well because he couldn't stand up. He was having a lot of problems. He's a retired Army colonel a month ago, and he says, I'm wonderful. I've been taking treatments. I've now had 600 treatments since I've seen you. Well, I said, that's remarkable. Where have you been taking them? Well, he said, I have my own chamber. He said, I'll bring it and show it to you. And there it is. He said he had it made in Mexico for $2,000. This is the second one because the first one blew up. And I'm not sure this one isn't going to blow up too, because I said, what are you doing there? Well, he says, I've got an electric fan. So you can imagine, electric motor in an oxygen-rich environment. See, he compresses this thing with air, but he takes the oxygen through a mask, and the mask is exhaled into the chamber where the electric fan is. So we had a few words with him about that. So chambers come in all types, sizes, and shape. This one's available in Mexico for $2,000. I'm sure the trailer is somewhat extra. But basically, this is what we're talking about, isn't it? This is the bloodstream. Here are the red cells. This clear stuff is the plasma. And here are the tissues. After hyperbaric oxygen, everything becomes supersaturated. So really, what we're dealing with is high-pressure inhalation therapy, isn't it? This article was published in 1960 in a very reputable medical journal. This was done by Dr. Borema in Amsterdam, and what he did was he took a series of pigs. He totally exsanguinated them, took every drop of blood out. He ran in sugar and salt, and he treated these pigs. He did this at 66 feet, or 3 atmospheres absolute. Kept the pigs in there an hour, 90 minutes. Then he retransfused half of them, put them back on the farm, and sacrificed the other half. He found no pathology in heart, lung, brain, kidney, spleen, bone marrow, no place. So what we have here is a modality to completely replace the need for blood to deliver oxygen to the tissues. This is rather astounding, and this fact isn't even taught in medical school. But think of this for the Jehovah's Witness. It's a godsend. And think of now with the situation with AIDS where so many people don't want blood. And believe me, they're right. The Jehovah's Witness with virtually no hemoglobin can be put into the chamber 3 or 4 times a day and will rapidly build up their own blood. So here we have a methodology that completely replaces the need for blood to furnish oxygen to the tissues. Now just think about that. What does that mean? How about in a stroke where the blood is blocked? How about in a leg vessel where there's no blood going through? How about in other areas of the body where the tissue oxygen is low? If you can get the oxygen there without blood at all, why not put these people in the chamber, dissolve the oxygen in all the body fluids and tissues, even though some of the perfusion is retrograde? It's a potent vehicle, and hyperbaric oxygen has not yet come into age. I just want to mention some of the conditions in which this is both emergency and life-saving, but let me tell you that in most conditions, hyperbaric oxygen is simply complementary or additive. The conditions in which it is primary, and unfortunately this primary has been decided by the legal profession, is gas gangrene, carbon monoxide cyanide intoxication, and air embolus, where air gets into the bloodstream either with the worst type of decompression illness or with cardiac catheterization, bypass surgery, again dialysis, venipuncture. Now these are some of the emergency conditions and where this makes a great deal of difference. We'll talk a little bit later about head injuries. It causes the blood vessels in the brain to constrict, yet delivers more oxygen, and therefore takes down a lot of swelling of the brain. Severed limbs will be the last topic today, but diving accidents and bends are very mistreated throughout Florida. In Israel and in the Mediterranean, they have portable chambers. They'll go, they'll rescue a diver, he'll put him under pressure, take him to a hospital, to a larger chamber. They do all this with helicopter. They do this with the near drowning victim, the little kid that falls into the canal or the pool. They do it with the near hanging, the electrocution. They go to the scene with pressurized oxygen. They're very far ahead of us. Smoke inhalation, carbon monoxide explosion, where air gets into the system. The blood loss anemia is typical of the Jehovah's Witness, and it's very helpful in the black race for the crises of sickle cell anemia. I just mentioned these to you as some of the emergency uses of this. There are probably only a half a dozen hospitals in the United States that have this in their emergency rooms, yet there are over 1,000 chambers in Russia, and in Japan you're never more than an hour from a chamber. Now, it's used rather extensively in this country for healing of wounds, whether it be a fracture, whether it be a gangrene, or whether it be a leg ulcer. But some of the effects of it, in particular reference to the fracture, increases the oxygen in the tissue. We've seen that. But in any type of infection or non-healing area, it causes little blood vessels to grow in very rapidly, and then it lays down the ground substance for support. The white cells become much more effective, and it has a killing effect on many bacteria. It also stimulates new bone activity, and it will tell either cartilage or bone to grow. It's rather remarkable. Now, some of the things we treat besides fractures that don't heal are bed sores, osteomyelitis, which is an infection of the bone, burns, Berger's disease, which is a characteristic vascular disease of the Jewish race, the bone infection, crust injuries, diabetic gangrene, diabetic wound, draining abscesses, infections secondary to chemotherapy. So oxygen under pressure has a healing effect, and we've just gone over some of the things it's done. We also treat a lot of leg ulcers and a lot of decubiti ulcers that occur in nursing homes. Radiation soft tissue damage, which can even occur in the spinal cord, but we see a lot of it in the mandible, in the jawbone. It's very common there. And we see it in the bladder, and we see it in the colon. And it's excellent to prepare an area for skin grafts. The area just pinkens up, the infection goes away, and all of these little new blood vessels grow into the area, and it really cuts down on hospital time and the degree of morbidity. We had burns up there, which is a controversial subject, but the overall results with burns, and I'm speaking serious burns now, I'm speaking 40 to 60% of the body, it takes a third less fluids to treat a patient like that because the oxygen clamps down on the blood vessels. They're in the hospital a third less time, and a third less of them die. So it is effective in burns, but not generally accepted yet. This is a picture of leg ulcers of 30 years duration, and this is after 20 treatments with hyperbaric oxygen. Obviously, everything else had been tried. Here's a chap that was sent to us the day before his leg was to be taken off. Let me tell you, the average price of taking a leg off below the knee in the United States is $65,000. Now that includes the surgeon's fee, the prosthesis, and the physical therapy. This fellow made a non-eventful recovery and went on to work as a salesman for a number of years. So if we talk about tissue regeneration and healing in the skin, a compromised graft that the plastic surgeon puts on, either to close something or a facelift or something, it's not taking. The area becomes purple and disaster is around the corner. But hyperbaric oxygen can save almost 100% of these. It also is specific for leprosy, and I'll just interject a little story here. This is both true in vivo and in vitro, and several friends of mine went to the leprosarium in South Carolina. They had some money and they volunteered a chamber to treat all the lepers there for nothing. They were just going to give them the chamber, and the administration wanted no part of it. They wanted absolutely no part. It is similar to the story of the Cancer Society, where about 10 cents on the dollar gets to the patient. Don't rock the boat. A severed ear is one of the biggest problems the plastic surgeon has. In fact, there have only been one case reported in 1890 where a horse bit a man's ear off, and a surgeon named Brown sewed it on with tailor's thread, and it took. Now, in the time interval there have been virtually no severed ears put back on that took. The surgeon usually takes the skin off the ear, throws it away, and buries the cartilage behind the neck or in the abdomen, and then $10,000, $20,000, $30,000, $40,000, $50,000 later, the patient ends up with a terrible-looking monkey business ear. We've had 3 of these lately. You can see that a large segment of the ear was gone. The patient came from the operating room right to the hyperbaric chamber, took about 30 treatments, and ended up with a very usable, beautiful cosmetic ear. Now, the bone doctors are the ones who use a lot of hyperbaric oxygen, but not in Fort Lauderdale, because they tell me they don't see any of these conditions. So my compliments to them. These are some of the things. I can't go over all of these, but the crush injuries, they have a lot of automobile accidents down there, and then compartments in the legs or arm get terribly swollen, under the fascia, under the tendon, and they go in and they just lay these things open like you would fillet a fish. These things respond beautifully to hyperbaric oxygen. Clostridium myonecrosis is gas gangrene. Now, there have been a number of lawsuits for failure to use hyperbaric oxygen in gas gangrene, because just simply with the ordinary treatment of gas gangrene throughout the world, the mortality rate with the best of antibiotics, with the best of surgery, is 36%. Now, all you do with hyperbaric oxygen is put the patient in the chamber once before the surgeon operates. And what this does is it neutralizes the toxins, which are the lethal effects. One treatment, and the mortality rate falls to 9%. Unfortunately, the attorneys know more about that than the doctors. Severed limbs will be my last topic. Bone infections, we've treated a number of patients who have had these since the Second World War. Bone grafts, which are becoming more and more popular, take well. Non-union of fracture, I think we have a slide on that. Delayed wound healing, stump infection, and swelling under a cast. And then the various types of ulcers, whether they be diabetic, due to nerve damage in the vein or in the artery, and then the old bed sore on the buttocks. All of these things respond. But I do not want to create the idea that this is a universal panacea. In all of these conditions, standard things are going on too, including surgery and antibiotics. Under these circumstances, hyperbaric oxygen is complementary. This is a Canadian labor leader. Can you see these cracks right through here? He had that for 3 years. They put pins in, nothing happened, it just didn't heal. The poor chap lost his family. He resorted to alcoholism. He was just totally hopeless. And we gave him 20 hyperbaric oxygen treatments. This is 3 years later, and the thing healed up. And he made a complete recovery orthopedic-wise as well as emotionally and mentally. So it's a powerful thing. It's nature's way. Now, in bone, we've been over some of these things. I just want to show you, this is magnetic resonance imaging. Are all of you familiar with this? This is the latest imaging technique that's available, that the patient is put into a magnetic field of about 3.5 to 5 Gauss. The magnet's turned on, and the nuclei of the hydrogen ions follow the pattern of the magnetic wave. Then the magnet is shut off, and as these things return to normal, they set off a certain radio frequency. These frequencies are picked up, computerized, and come out with a beautiful image. This area is what's called aseptic necrosis, avascular necrosis. It means that there wasn't any blood going to this joint, and this joint died. This is a very common condition. We used to think that it was associated only with divers, but it's far more common than we suspected. And now with the magnetic resonance, we can begin to see this. This was a 32-year-old trial lawyer. He had been advised total hip replacement. But the problem with it is that it would probably crop up in the other joint, and then it would hit the shoulders. So he opted to go for the hyperbaric oxygen. This is just a bigger area showing how much of this bone is gone. But after the hyperbaric oxygen, you can see all of this now is beginning to fill in. And there we are, just with hyperbaric oxygen, no surgery. This, incidentally, does not make us too popular with the orthopedic surgeons. Now, let's talk a little bit about where my feeling is that the biggest and the future use of hyperbaric oxygen lies. And that's for its use not particularly in wound healing and bone healing and infections, but in the central nervous system. I've been working with multiple sclerosis now since about 1974. I've treated about 1,200 patients. And let me be the first to tell you, I never cured one. Hyperbaric oxygen in multiple sclerosis is dose-specific. Remember, pressure and time, number of doses. It's dose-specific. It must be continued. And when the proper cases are chosen, I'm not talking of wheelchair patients, but we'll go over the specific indications. When the cases are selected properly, about 75% of the patients will undergo an alteration in the course of their disease. There is no cure for MS. Nobody knows the cause. It's a terrible disease. I'm not being unkind. The problem is the MS patients do not die. With antibiotics, with proper treatments for supplemental things, the patients go on, and just some of them are tragic cases. But how we measure the effect is the alteration in the course of the disease, evoked potentials, which are electrical pathways, and magnetic resonance imaging. I just want to show you some of the MRI changes that occurred. You see these little dots? These are MS lesions in a patient. And there we are after 20 treatments. Now, what we'll do is cut right through the brain with other cases. Here we have some in the pontine area, which is the area that controls breathing. It controls the vital functions. And you can see these areas of swelling. And this is after the first area. The edema, the swelling begins to go down. And here we are after 20 treatments. I think this could have been the chap that had that little chamber. So I guess we did him a favor. Now here's another one in the cerebellum. These great big things are white matter lesions compatible with multiple sclerosis. Now please, if I'm going too fast or you want to review any of these, just please stop me. But here we go. These lesions begin to disappear in as little as an hour. And after 20 treatments, they're virtually gone. Another method of assessing it is, you don't have to be a neurologist to read this, but it might do better if I had put it in properly. Anyhow, it's reversed. This is the crazy evoked potential that we were dealing with the patient. And after 20 treatments, you can see that this is a more organized. We've gotten rid of all of this business, and it's now come into a nice pattern. This was the visual or the optic evoked potential done in this patient after 20 treatments. There have been now over 10,000 patients treated throughout the world. The results are reproducible. It's difficult to assess any type of treatment in multiple sclerosis. The only way you can tell if anything is successful in MS is longevity. And the dean of multiple sclerosis, Dr. Schumacher, in the 70s decided that there was no way to double blind or to really assess this disease. So he came out with the dictum that if the patient is no worse after 2 years with any type of treatment, that you've got a good treatment. Currently, there are 6,000 patients undergoing this treatment in the United Kingdom. They buy their own chambers, they treat each other, and the 3- and 5-year results are now beginning to be tallied. And it's very obvious that the patients who take hyperbaric oxygen, dose sensitive, and stay by it, fare far better than the others. It does alter the course of the disease. Now, it's not for everybody. We use it primarily in the acute attacks. We use it in the ones that come and go. And we use it in the chronic progressive, but not the wheelchair ones now. We don't cure these people, but if a patient, about 80% of them get a lot of improvement in the bowel and bladder, and you have no idea what that means to the patient. The eye, the balance, the ability to move the muscles, and the lack of fatigue is a tremendous, tremendous thing. We wonder if somehow this isn't similar to Epstein-Barr virus, but nobody's ever been able to prove a virus in multiple sclerosis. This was a chap over in Scotland. He was a fiddler in a marching band. He ended up in a wheelchair, and he was treated by a friend of mine over in the UK, and here he is after his treatments with MS. So it's things like this that make it all worthwhile. Now, I told you I thought that this was important in neurologic conditions, so let's talk about some of these. We've talked about MS. Stroke. Well, we all know what stroke is. That's an interruption of the blood supply to the brain, and depending upon the area and the degree of interruption, makes a difference whether the patient is going to live or die, be paralyzed, or recover. Multi-infarctional dementia. This is a term, this is really hardening of the arteries with a whole bunch of little strokes where the patient becomes gradually senile. It's not Alzheimer's disease. There's a big distinction because hyperbaric does not work in Alzheimer's. Closed head injury, automobile accident, somebody falling, somebody diving into a pool, swelling of the brain. Cerebral anoxia, this is when the blood supply to the brain is cut off. This happens with carbon monoxide. It happens with the little kids that drown. It happens with lightning or electrocution. And any time the blood is cut off to the brain has a common denominator to react. It swells in its own bony confinement, and it pours out a lot of toxic chemicals, and it virtually kills itself. Now, hyperbaric takes down this swelling, and it takes care of the lack of blood, and a lot of these things disappear almost immediately. It's tragic. There's a ward down in Fort Lauderdale where they have nothing but little kiddies that have fallen into the pool or the canal. The 9/11 people rush, they resuscitate them, the picture's on the front paper, and 3 weeks later you read that the little child has died of intercurrent pneumonia. It's unfortunate that these little children are not placed in a portable hyperbaric unit and brought and treated with what we think is the state-of-the-art. Brain inflammation, abscesses, vegetative coma I want to talk to you about. Spinal cord pathology, they have raised millions of dollars in Miami because a football player's son, Nick Bonaconti, developed a spinal cord pathological injury while playing. They have completely circled hyperbaric, even though they have a chamber in the hospital. The migraine, the vascular, the Bell's palsy, the other things that you hear about, the facial paralysis, at times are helped. Now, I've shown this to neurologists, and they tell me this is a stroke, and this is the area around the stroke. But actually, this is a sunspot. And this is the penumbra, and this is the area around. Now, what are we talking about? We're talking about the ischemic penumbra. Penumbra is a partial shadow between the regions of complete shadow and complete illumination. Partly darkened fringe around a sunspot, an outlying surrounding region, periphery ring. This is what we look at with hyperbaric oxygen in neurologic diseases. We are not in the resurrection business. We make nothing over. But let me tell you what happens in a stroke, closed head injury, and a lot of other things. The area that you saw in the center, the umbra, that tissue is gone, irreversible. But the penumbra, the light area, some of this is suffering from electrical failure, but it's not dead. The problem we have in the medical world is the neurologist, all of their methods of measurement are electrophysiologic. So if they see a patient in coma or a patient with stroke, and they do these measurements and nothing happens, they say the tissue's dead. Not necessarily so. A lot of this tissue, given the proper amount of oxygen and glucose, will fire off again. The critical parameter of tissue function is oxygen availability rather than blood flow. Published 1981 in the journal Stroke. Electrical activity, energy metabolism, and ion pumping respond almost immediately to appropriately reduced supply of oxygen, while the development of infarction or stroke appears to have a considerable time factor involved. Now, wouldn't it just be sensible to put these patients in the chamber and see how much could be preserved? Now, how have we measured this? This is something I published in Stroke a number of years ago. What it says is that we took a matched group of patients. We had the same neurologist, we had the same measurements, and we matched them to age, sex, economic background. And what we found, we treated one group with hyperbaric oxygen, and the other group was just treated in the routine way. And we found really that the death rate was not significantly different, but with the HBO treatments, all of them went home. Whereas what happened to the regular ones? 9 of them went to a nursing home. And of course today with the DRGs, or diagnostic-related groups, hospital cost is a tremendous thing. So we added up the total hospital days for the HBO, 177, and the untreated, 287. In fact, certain of the hospitals today where they have chambers are simply giving the treatments away because they get the patient out faster and they make money. These are some slides. They're not nearly as detailed as our French counterpart on a cellular level, but let me tell you what these are, because you're only the second audience to ever see these. Could we focus these a little better, please? The MRI pictures that I showed you show you an anatomical point in time. Now, this is a different study. This shows the actual metabolism of the brain, and this is all color-coded. These dark bluish to black areas are areas that are virtually dead. The closer to white and yellow, the more active the brain tissue is. But look at these big holes in here. Now, these are before hyperbaric oxygen treatment. Now, we're looking now at actual living tissue. This is done with a gamma camera called spectramine. But the changes in colors, if any of you want to view these later, I'll be glad to show them to you. But the changes that take place are just remarkable. So we're very excited about this as a specific way to identify what tissue is viable. And what we're really looking at is we're looking at this ischemic, the penumbra, the area outside, the marginal cells, the ones that will fire off again. So for the first time, we're now able to look at a stroke patient or one with hardening of the arteries and see how much tissue is idling, how much is viable, and what the possibilities are for therapy. So we're very excited about this. I say I'm sorry we don't have more time to get into individual detail, but this is the spectramine study that we're currently doing, and we're doing these with controls and on strokes, and the results are really very startling. Now, I told you that in senility, or Alzheimer's disease, that really there's no effect. But if you take the patient grandmother or grandfather with hardening of the arteries, some of these slides we've just seen, and you get them within the first year when they're getting a little funny, where they're beginning to hide things, where their personality is beginning to change, and you treat them with hyperbaric oxygen, in selected cases we can probably do something for about 70% of these. This is not for everybody. It's not for grandmother or grandfather who's in the nursing home. It's for the ones with the idling, with the marginal neurons. Now, we should be coming into, this was the organic brain syndrome that we were just talking about. The spinal cord contusion, if we have time, we'll talk about that, but I want to talk to you a little bit about the vegetative state. We've been through this anoxia with the swelling of the brain, the carbon monoxide, cyanide, all of these other things, where the portable chambers must someday become available. I don't expect you to follow everything on this slide. I just show this slide, and we've updated it from 24 now to 30 patients of vegetative coma that have been treated with hyperbaric oxygen. Now, what do I mean by that? I mean a patient that's neither dead nor alive, kind of like the Karen Quinlan case. With excellent nursing care, they just lie around. They're neither here, they're neither there. The outlook is about zero. When one does come out of coma spontaneously, it makes world television news. We felt that since the electrophysiological measurements were no good, that we would take one or two of these patients and treat them intensively with hyperbaric oxygen. I mean, we set a figure of 120 treatments. And it worked. It worked in some of them. This is the type of case that we dealt with. Now, I've published this in Minerva Medicine, and all this has to do is with the idling neuron. These are the observations on how they began to come out of coma, and these are the coma score, which is a kind of way to assign a number to these patients. Let me tell you that out of 30 of these, we've now had 50% of them totally rehabilitated. It's not for everybody, but certainly if there are neurons that are still viable, that can be reactivated with the proper amount of oxygen and glucose, this is a safe, harmless, economically feasible way to do it. The insurance companies are crazy about it, because anybody that would attempt to do anything positive for a vegetative coma is welcomed by the insurance company. Now, I show this because a friend of mine completely severed the spinal cord of about 40 rats. And if you ask any neurologist or neurosurgeon what will happen, they'll tell you nothing could possibly happen. He treated these rats with hyperbaric oxygen, and 25% of them got up and walked. I have photographs of the neural tissue growing through the scars, but in view of the lack of time this morning, I just pulled them out of the file. But 25% of these rats could bear weight after having the spinal cord sectioned. Now, I'm not that optimistic in the human. In the human, another tragic thing that happens is some young person on a motorcycle falls off or dives into the shallow end of a pool, or a construction worker falls and they bruise the back of the neck. And what happens with this bruise, you get the swelling, and then you get clots, you get lack of blood, you get all types of biochemical abnormalities. And what's really happening is that the spinal cord is swelling in a bony confinement. There's no place for it to go. And as it swells, it completely destroys itself. This has the medical term of physiological transection of the cord. It's tragic. You watch these young people that were very healthy till they dived into the pool, and they develop an ascending paralysis. It begins with the toes, the feet, all the way up, including the chest, and they're that way permanently. This does not replace surgery if there's a fragment, but in the specific bruising of the cord, if these patients can be brought to the chamber within the first 6 hours, they will recover. It's a very dramatic and very important thing. Now, this, again, is not a panacea. It does not work in senility, does not work in Alzheimer's disease, it doesn't work in ALS, doesn't work in muscular dystrophy. Steve, I think I have another canister that I just want to run through. I believe I have about 5 more minutes. I want to show you the ultimate in tissue healing and regeneration. These slides I'm going to show you came from Liège, Belgium. There's a whole other canister to go on. Anybody have any questions so far? As I say, I can't see a thing, but please interrupt me at any time. Or, like any other drug, it's a poison if not used properly. But when used between 1.5 and 3 atmospheres for periods not longer than 2 hours, it's much safer than aspirin. There are no side effects. The occasional patient will get a pressure squeeze. It's like going up and down on an airplane. Some people have to clear their sinuses and their nose in order to ascend and descend. Yes.
What is the defect in the MS patient? That's all in the brain, that they're paralysis and...
No, they used to think that MS was only a disease of the brain, but it's a disease of the spinal cord. It's interesting, some recent data shows that the pathological changes in the spinal cord of the MS patient and of the diver, commercial diver, are identical. You cannot tell the pathological changes apart. But a large percentage of the MS patients have it in the cord. Now, most of them will have it in the brain too, but certain cases just have it in the cord. We're beginning to pick up on this now with MRI imaging, with some of the newer software. You can actually see the lesions. Are we having a problem getting that other canister on? Oh, I'm sorry.
Can I ask one further question on the brain picture that you had?
Yes.
Swelling. Was that swelling or was a nerve cell dead?
Well, the only way we could tell it's swelling is it went down. But these are white matter changes. They're water content changes picked up by a long relaxation period of T2. The only reason we say there's swelling is that it went away. If it hadn't gone away, then it would have been a precursor to possible permanent damage. Or it may...
Nerve cell dead, though.
We don't think so, not as long as it went away. We think that it's a precursor. It was disease in the white matter with the edema and the early demyelinization, but we don't think that it went that far. And this is why all of these patients should be treated appropriately. Now, how do I get the next slide? Now, to wind up on survival regeneration, I hope all of you didn't have too much breakfast.
May I have a question? May I have another question?
Yeah? Yeah, let me just finish, then I'll be very happy to talk with you all day. These cases came from Liège, Belgium. There's no place in the United States where this work can be done. The only place where this has been duplicated is in Beijing, China, where they have a large hyperbaric center. Now, if you see what's happened there, this chap had the arm almost totally avulsed. And yet with hyperbaric, and compliments to the surgeon, don't misunderstand. I've shown these to reimplantation surgeons in the United States, and they say this can't be done. Foot. Isn't that remarkable? We just chop things off and throw them away in this country. All of this can be done with the secondary effects of hyperbaric oxygen. So if I may close, paraphrase Shakespeare, here is better than the open air. Take it thankfully, and let me say to you, if any of you are ever in Fort Lauderdale, please drop by and visit us. Thank you so much. Yes.
Could you please refresh my partially forgotten knowledge of physiology? I was taught that a hemoglobin transports oxygen into the mitochondria of all the cells of the body. Now, if oxygen with a higher pressure is now dissolved in the blood, how is it dissolved? Is it dissolved?
It's physically dissolved according to Henry's law. It's dissolved in all body fluids.
It has nothing to do with hemoglobin.
No hemoglobin, you can still meet all of the body's requirements for oxygen with hyperbaric.
And how is it transported into the cell if it is if it is only physically dissolved?
Well, you see, you've got plasma, you've got lymph, you've got bone, you've got urine, you've got cerebrospinal fluid. You have a retrograde perfusion as well as a direct perfusion.
Right, but how does it get through the cell membrane into the actual mitochondria?
Well, the same way it does if it's transplanted with hemoglobin. The mechanism is the same. You are delivering it, and the effects are the same as Dr. Borema showed when he sacrificed half of these animals. There was no pathology in any organ. So the effect is identical with the oxygen that's transplanted or transported by hemoglobin. Maybe we could talk about this a little later. There are a couple of other questions, and I don't want to.
I have two questions. Have you used it for regeneration of bone after radiation therapy for bone cancer?
Absolutely. Works beautifully. Absolutely.
Does it work when the cancer is still present?
Yes, it will regenerate the bone, but it also augments the chemotherapy and the irradiation. Now, this was pure hyperbaric plus physical therapy. I think the electrical stimulation certainly has a place in a lot of these limb problems. But let me just interject. I had a terrible experience with that. I sent one of my patients with an ulcer up to a very competent physical therapist, and he was out of town. And somebody put an electrode on there and burned the patient. And he lost part of his foot, and we all got sued handsomely. It was my fault because I had sent him to the physical therapist. So, but I think ferritic and low voltage stimulation does play a role, but certainly we've got to be terribly careful.